Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about caring for patients with bladder cancer with Dr. Ghali. Dr. Ghali is an assistant professor of urology at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
Maybe you can start off by telling us a little bit more about yourself and what it is you do.
I'm in the Department of Urology with my focus is urologic cancers. So that includes cancers of the prostate and kidney and bladder, as well as the ureter and some other malignancies. And my focus even within that is urothelial cancers, which would be bladder cancer and cancers of the ureter. So that's my main clinical focus, and I also have some research interests at the School of Medicine, which also involve bladder cancer primarily.
So let's talk a little bit more about bladder cancer. Can you give us a landscape of, how common it is, who gets it, what are the risk factors?
Of course. Bladder cancer is unfortunately quite common. Depending on the breakdown, it's either the fifth or the sixth most common cancer affecting Americans. Approximately a little over 82,000 Americans will be diagnosed with bladder cancer every year. So unfortunately, it affects a lot of patients. And of those patients, the mortality is higher than we would like to see. Approximately over 16,000 Americans succumb to bladder cancer every year. So it's a real medical problem that we see. Bladder cancer primarily, it affects both men and women, of course, but it affects men more commonly than women, actually about 3 times more commonly than women. And that's what we see in practice as well, is we definitely see it affecting male patients more frequently. Not that female patients don't get it, but just less commonly. So that's sort of a basic landscape. And there are some risk factors, like you say, for bladder cancer. By far, the most common risk factor we see here in the United States is smoking. Smoking increases patients' risks for developing bladder cancer 3 to 4 times higher than the general population. And it's a real, it's a really important one because it's so modifiable. We can, that's something we have a clear impact on in terms of our health. There are other risk factors. There are certain chemical dyes and certain exposures, workplace exposures, specifically certain types of chemicals that are associated with bladder cancer. Those are less commonly seen here in the United States, but can be seen. And there are certain infections and other medical exposures that are less common here in the United States, but are seen more in other parts of the world that can be related to bladder cancer. Certain parasite infections of the bladder, which are seen more in the Mediterranean and in North Africa. Specifically, a parasite called schistosomiasis can be related to the development of a type of bladder cancer. So, definitely multiple risk factors, but I would say smoking is the main one that we see here in the United States, and the main one that I like to focus on with my patients because we have such a clear impact on that. And
so, one of the things with smoking, of course, is that it's really hard to quit. So a couple of questions with regards to that. First, let's suppose you are a smoker and you did develop bladder cancer. If you quit, does that reduce your risk of recurrence? Second, if you're a smoker and you haven't developed bladder cancer, is it too late? In other words, if you quit now, do you reduce or potentially even eliminate your risk for developing bladder cancer?
Those are both excellent questions. I'm glad that you brought those points up. To your first question, if you have bladder cancer and are a smoker, does quitting smoking improve your outcomes in any meaningful way? And the answer to that is almost certainly yes, it does. We know that quitting smoking even after diagnosis decreases, it's not a huge margin. It's not the same as some of the other treatments, but it's definitely detectable that it decreases the risk of bladder cancer recurring again in the future. So it's something that I encourage all my patients, to really think about and consider, because sometimes, like you say, quitting smoking is a very big challenge, and sometimes a diagnosis like this is just the impetus and just the motivation one needs to take that leap and really do this. Your second question is, if you quit smoking before a diagnosis of bladder cancer, does it decrease your risk of developing it? Or once you're a smoker, sort of always a smoker, you've incurred that risk? And again, there's pretty good population level evidence that the risk of smoking is, first of all, it's dose dependent, meaning if you smoke more and if you smoke longer, that risk of developing malignancy increases. On top of that, when you quit smoking, your risk reduction improves with time. Sort of the longer ago you quit, the lower your risk of developing cancer goes, and it sort of starts to mirror the risk of the general population over time. So that at about 10 to 15 years after you quit smoking, after a patient quits smoking, I tell my patients that at around that time, you're sort of close to the baseline exposure, the baseline risk of developing bladder cancer as the general population. So on both sides, whether before or after a diagnosis of bladder cancer, there's still a clear indication to quit smoking and kick that habit if possible. And I tell patients in clinic frequently that it's so easy for me to say, and it's so easy to just talk about casually like this, but I acknowledge that it's a really challenging thing for them.
Yeah, and true enough, it certainly is challenging, but there are resources that can help people quit smoking, right? Can you talk a little bit about what are some of the things that you encourage patients to do, whether it's, going to a smoking cessation program or a quit line? Like, are those resources available in the community, and do they work?
Yes, these are things that I encourage patients to do. We do have a smoking cessation program at the hospital where I work, and it's really quite robust. And there are providers that specialize specifically in helping patients achieve this goal. And so, one of the things that we try to do is make sure to connect patients to resources like this. There are multiple prescription medications like nicotine replacement supplements, which can also improve patients' success rate in quitting smoking. On top of that, sometimes it's, especially for patients who've been smoking for a long time, and for them it's related to social or other sort of benefits that aren't just, that aren't just the habit alone, but they have other reasons that they're smoking. It's sometimes helpful to talk to mental health providers or other practitioners who really are effective at changing harmful habits. So there are a lot of resources, especially, we're very lucky to have lots of resources here. But most major health centers have some capacity to help patients achieve this goal. And, that speaks to the fact that this habit is related to a lot of adverse health outcomes, not just bladder cancer, of course. And so lots of different groups in the hospital and different providers have a strong incentive to really help patients quit smoking.
Yeah, absolutely. One of the questions that people may ask surrounding quitting smoking and the risks of various things, whether it's heart disease or cancer, but in this case, bladder cancer, is if smoking causes bladder cancer, if I replace the smoking with nicotine, isn't that still just a chemical? And doesn't that chemical also increase my risk?
It's a good question. And, this is an especially important question as we've gotten other cigarette supplements like, electronic vapes rather, and things like this. And the question is, how does the risk from those types of exposures relate to the risk compared to cigarettes? We don't know a lot of those answers. We're learning more and more about the impact of some of these exposures on the lungs and some of these exposures on other parts of the body that we see more immediately because we have shorter term data on them. The risk of long-term things like the development of bladder cancer, which doesn't happen, of course, immediately, but happens over time, it's sort of a cumulative exposure risk, is less well known. I definitely don't recommend it to patients, but it's hard for me to associate specific numbers with those things. These are things we're learning. What I'll say is that it's hard to imagine that these risks are as bad as smoking. Smoking is associated with, we know so much about the harms of it that it's almost certainly a more extreme sort of example of some of these risks, but we don't know that for sure.
Which brings me to other occupational exposures. So in addition to smoking, you had mentioned that there are various chemicals that one can be exposed to either environmentally or occupationally, which increase the risk of bladder cancer, and these risks are relatively well known. So then the question is, how do I know if I'm in a workplace or in an environment that has exposure to these chemicals? And if it is an occupational exposure, how come the government isn't banning them if we know that there's a strong risk with bladder cancer?
A lot of the substances that have historically been described, these particular compounds that are associated with certain dyes, for example, in clothing or hair dyes, is sort of the classic example, are not commonly used anymore. And so I don't know the exact incidence of bladder cancer associated with those dyes from contemporary data. A lot of these descriptions are sort of data that come from are more historic exposures, I would say. That's not to say that they don't occur anymore. I would say that they're it's definitely not a common thing that I see clinically, I should say.
The other risk factor that many cancers have, but that you really haven't touched on yet, and I was hoping to get your thoughts on, has to do with genetics and family history. Is bladder cancer something that, if you have a family history of it, it increases your own personal risk?
Yeah, that's a good question. There are certain genetic risks associated with bladder cancer. There's actually a related malignancy to bladder cancer that is that we talk about which is ureteral cancer of the ureters, the tubes that drain the kidneys from the bladder, that has a very clear genetic risk, specifically with a disorder called Lynch syndrome. It's a heritable genetic risk that's associated with urothelial cancers, more the ureter than the bladder. The bladder does seem to be bladder cancer is slightly at an increased risk compared to the general population for patients with this genetic disorder, but definitely not as elevated of a risk as in the cancer of the ureters, this sort of associated cancer. As far as whether or not having a parent or siblings or first-degree relative with bladder cancer raises your risk, the answer is it does very slightly, but not as much as other cancers. We don't think of it as quite as heritable. That being said, there's no doubt that a family with a long history of bladder cancer or especially high rates of bladder cancer, it does seem to be, it does increase an individual's risk slightly, enough to detect it in population-level data.
Great. Well, we need to take a quick break for a medical minute, but please stay tuned to learn more about the care of patients with bladder cancer with my guest, Dr. Fed Ghali.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where all patients have access to cutting-edge clinical trials at several convenient locations throughout the region. To learn more, visit smilowcancerhospital.org. There are over 16.9 million cancer survivors in the U.S. and over 240,000 here in Connecticut. Completing treatment for cancer is a very exciting milestone, but cancer and its treatment can be a life-changing experience. The return to normal activities and relationships may be difficult, and cancer survivors may face other long-term side effects of cancer, including heart problems, osteoporosis, fertility issues, and an increased risk of second cancers. Resources for cancer survivors are available at federally designated comprehensive cancer centers, such as the Yale Cancer Center and its Milo Cancer Hospital, to keep cancer survivors well and focused on healthy living. The Milo Cancer Hospital Survivorship Clinic focuses on providing guidance and direction to empower survivors to take steps to maximize their health, quality of life, and longevity. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anise Chagpar, and I'm joined tonight by my guest, Dr. Fed Ghali. We're talking about the care of patients with bladder cancer, and before the break, we spent a lot of time talking about what exactly is bladder cancer. Interestingly, it's perhaps more common than many of us think. One of the fifth or sixth most common cancers we see here in the U.S. We talked about how it was associated with smoking and various chemicals, as well as slightly related to family history and some genetic syndromes. But Fed, I was hoping that now we could kind of pick up the conversation and talk about what are the signs and symptoms that people might present with when they come in with bladder cancer. It's not really a cancer that we screen for, right?
That's correct. We don't routinely screen for bladder cancer. And just to clarify, by screen, we mean taking healthy, asymptomatic patients and basically doing some test or exam to search for bladder cancer when there's otherwise no good reason. We don't routinely do that, and it's not recommended by any of our national guidelines here in the United States or elsewhere. And the reason is because screening has both benefits and downsides, and the sort of the assessment of the benefits and risks hasn't sort of shaken out to recommend routine screening. So we don't screen for bladder cancer, and instead we wait until there's a reason that one should look for bladder cancer, do an diagnostic assessment for bladder cancer before we really do a workup.
So presumably then patients who have bladder cancer would need to present with some sort of symptom. Can you talk a little bit about what are the warning signs? What are the symptoms that should prompt people to seek medical attention that might turn into bladder cancer?
Of course. Like most cancers, cancers can present with a lot of various symptoms depending on sort of how long it has been there and where it is in the natural history of the disease. But by and large, the most common symptom that the patient would present with that would trigger a workup for bladder cancer would be blood in the urine, what we call hematuria. That's sort of the classic presentation for bladder cancer, and is definitely what we see most frequently in the clinic as well.
And so, sometimes people, when they go to the doctor just for their routine physical, they'll get a urine sample and sometimes when we get those reports back, there is a line there that says blood. So even if you haven't seen blood in the urine, is that another way that bladder cancer can present on one of these routine urine tests?
Yes, you're touching on an important distinction here, which is blood that is visible to the patient is what we call gross hematuria. And separately, what you're describing for blood that's seen on just the test, in other words, what I tell my patients, this is, you wouldn't have known there was anything going on. We told you there was blood that was seen under the microscope and so on. That's what we call microhematuria. And either one of those, the presence of either of those occurring is really a good reason to check in with a urologist and be evaluated. Now, like you say, microhematuria is more common than the more visible gross hematuria, and it's less associated with with a diagnosis of bladder cancer than visible blood in the urine, gross hematuria. And so the workup is not always exactly the same. Sometimes we end up doing very similar things for the workup, but both, at least warrant a discussion about a workup for bladder cancer and an assessment of other risk factors like we discussed earlier.
And so if a patient does have risk factors and hematuria or presents with gross hematuria, what does the workup look like?
So what I tell patients is that blood in the urine doesn't give us a diagnosis of cancer by any means. It just makes our ears perk up a little bit and sort of triggers us to do more investigation. And many times when we look more closely, we find other good causes, other benign causes for blood in the urine. And so there's a list of non-cancerous things that can cause blood in the urine, which I'd be happy to discuss. But once we embark on a workup for blood in the urine, the workup normally entails a couple of things. One is another urine test to ensure that there's no infection of the urine. So this is a common cause of blood in the urine, as many patients or many listeners will know. So we confirm that there's not an obvious reason that there's blood in the urine. We will also see the patient in clinic and do a full history and physical. We'll, understand any changes in their history recently, any recent trauma, for example, or any other changes in symptoms, that sort of thing. We'll understand a bit of their history. But ultimately, we will decide to do some type of imaging of their abdomen in order to evaluate their kidneys and often their ureters, those tubes that drain the kidneys down into the bladder. So some type of imaging is usually warranted, and the most common form of that is a CT scan. It's a special type of CT scan called a CT urogram, which is a specific protocol that we use that helps us really clearly visualize the kidney and the ureters, especially. It sort of allows us to zero in on those parts of the body, which are of course would be common causes of blood in the urine. And finally, the last sort of central part of a hematuria workup is a small procedure that we call a cystoscopy. And a cystoscopy is a procedure most often done in the clinic, and it's basically the insertion of a small camera, a small flexible camera into the urethra, and through the urethra into the bladder. And we physically fill the bladder up with fluid, and we look around in the bladder and make sure that we don't see any lumps or bumps or areas of redness or concern, and that we have fully just looked at every little bit of the bladder to make sure there's nothing that warrants further treatment. And so between the history and physical, and then the urine test, a CT scan usually, and a cystoscopy, that's what we sort of think of as a hematuria workup.
And so presumably, if on cystoscopy you do see a patch of redness or a lump or bump, that could potentially make you think about a bladder cancer. Can biopsies be done at the same time?
They can occasionally be done at the same time, but that is not routine to do it at the same time. And the reason is that if we see a lesion, something that looks like a tumor of the bladder, the next steps will be to find out what what the histology of that lesion is, sort of get a pathologic diagnosis and either confirm or rule out bladder cancer. And to do that, we almost always will basically stop the procedure at that time. We will suggest to the patient that we go to the operating room and remove the tumor in its entirety, rather than just take a small biopsy, which will give us a more successful diagnosis of the specific cell types and what is growing under the microscope, basically. But on top of that, we know that a procedure like this, where the whole tumor is removed, is really, it's not just diagnostic, but it's also therapeutic. If there is cancer there, it's really important that we remove the cancer from the patient's body. We get a better understanding of what we're dealing with, and doing a thorough resection of this tumor we know that it improves outcomes and decreases the chance of recurrence down the road. And so that's usually what we do if we see something suspicious, is instead of a small biopsy in the clinic, we will normally not put patients through that, and instead say, there really shouldn't be a whole lot growing on the inside of your bladder. If except with really rare exceptions, if there's something on the inside of the bladder, we usually would like to remove it in its entirety.
So a couple of questions on that. One, what's the breakdown between how many of these lesions turn out to be completely benign versus how many actually turn out to be a bladder cancer? And number two, can you kind of illustrate for us a little bit more about what you mean by a complete resection? Do you mean removing a portion of the bladder wall, or do you mean removing the whole bladder, which might be kind of scary for some patients?
Thank you. Yeah, that's a really important distinction. So let's talk about that. There are certain benign things that can grow in the bladder. There are certain types of inflammatory lesions or certain benign, almost polyp-like lesions that can grow. And I would say, I don't have off the top of my head a breakdown of the number that is malignant and the number that is benign, but it's not an insignificant number where we go into the bladder and we see what looks like a small growth or a little something like a cyst in the bladder, and when we look at it under the microscope, we find that it was some inflammatory change or something that wasn't cancer. That being said, many, and I would say most growths in the bladder that we see grossly, we can, especially urologists that see this type of thing frequently, can have a pretty good sense. I can look at a bladder lesion and really know with some confidence whether or not this is a concerning type or more of an inflammatory type. And that's sort of the trigger, is the gross appearance of the lesion. If it's suspicious enough, that's the trigger for doing this more involved procedure. So let me tell you a little bit about the procedure that is the most common procedure we do for this type of thing, at least initially. It's a procedure called a transurethral resection of a bladder tumor, a TURBT. It's a bit of a mouthful. And what this procedure is, we basically go under anesthesia in the operating room. We use a camera not unlike the one that's used in clinic, except it's a little bigger and more sophisticated, allows us to do more procedures through the channel of the camera. So we're not making incisions, we're not cutting out parts of the bladder, but instead are using an instrument, an endoscopic instrument that's minimally invasive, meant to hopefully cause the least discomfort and morbidity for patients. And we go to the operating room and pass that again through the urethra, the channel into the bladder. And through that instrument, we're able to sort of in piecemeal remove this suspicious lesion. We don't remove part of the bladder, we remove the tumor, and then we will try to remove some of the underlying bladder in order to get to basically to get an answer to the question of how advanced, if this is a cancer, how advanced is this cancer into the wall of the bladder? And that ends up being a very important question for deciding next steps for treatment, is what we call the stage of the disease, which is, if there is a cancer, is this cancer early stage in that it's very on the surface of the bladder, or is this more advanced, requiring, having advanced deeper into the wall of the bladder? And that, the answer to that question really helps us decide the best therapy moving forward.
Dr. Ghali is an assistant professor of urology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.